Good afternoon, everyone. My name is Mike Pinkerton, Chief Executive for Doncaster and Basildore Hospitals, and we are the Working Together programme. We're an existing partnership of 7 acute trusts in South Yorkshire, Mid Yorkshire and North Derbyshire, covering 15 hospitals, serving a population of 2.3 million, 45,000 staff and over 100,000 patient and public members. Established by a Memorandum of Understanding in March 2013, to work together to deliver benefits that the trusts working on their own individually could not achieve. And we're focused on improving quality, safety and patient experience through reductions in variation and inequalities in care, supporting local access to services whilst maximising use of skilled workforce across organisational boundaries, and delivering services that are both clinically and financially sustainable. We invested in a central PMO office in January 2014 to the tune of approximately £1 million, with the approach focusing on engaging frontline and clinical staff on innovative approaches to tackle common issues through a range of clinical and support services projects. Our improvements are clinically led and driven by user needs. Key success factors to date have been the leadership and ownership by the 7 chief executives guiding the direction and delivery of the projects, and clinical leadership through the Medical Directors Reference Group. We're also engaged with many other bodies as a programme with the Commissioners and NHS England, and we've stimulated and energised our local commissioners to form a parallel programme called Commissioners Working Together. Also through Health Education England and the Academic Health Science Network. And our patient involvement approach is to use our existing partnerships and networks through our commissioners, through our own trusts, through the overview and scrutiny committees and our health and wellbeing boards, and develop our approach as a bespoke necessary. And we had one of our first patient and public engagement events earlier in the year. I'll now pass on to say what we've achieved thus far.
Thank you. I'm Richard Jenkins. I'm the Medical Director of Barnsley Hospital FT, and I chair the Working Together Partnership Medical Directors Group. So over the last 2 years, we've done a number of things, and we were really very highly motivated to do what we could to improve clinical services as a group of 7 trusts that we couldn't do on our own. And we selected the areas to work on based on a similar criteria to the Vanguard project to look at sustainability and equity of access. A lot of that pointed towards problems with out-of-hours services. So we've done a lot of work on reorganising out-of-hours services for ophthalmology services, ear, nose and throat, oral maxillofacial surgery, interventional radiology and gastrointestinal bleeding. None of those services are very easy to deliver across 7 trusts independently due to provision of workforce and other factors. We've done a lot of work on radiology, which we were hearing about earlier. We've also got a work stream looking at insourcing using IT-enabled solutions. We've also done a very important piece of work ongoing using the Calderdale framework to look at competencies of the radiology workforce so that we can redesign the workforce to take into account what we heard earlier about the lack of supply of the medical staff that traditionally models have been based on. We've done that work in partnership with Royal College and Health Education England. We've also done a lot of work on children's services. We've got 2 work programmes there, one on children's surgery and one on acute services for children, and that's done in partnership with our commissioners. We believe from these pieces of work we've developed a replicable model of bottom-up clinical engagement that allows these services to be redesigned by the people who are going to be working within them. We identified some crucial enabling HR and IT strategies through that work as well, and one of those, for example, is the use of the ICE OpenNet system, which allows diagnostic test results for patients in our patch to be seen in any hospital and improve care that way. We've had a big programme on procurement, which by the end of December will have delivered over £1 million of savings, and that's been supported by a lot of clinical engagement. So we've not only we've found products that are cheaper, they're also clinically acceptable to the people who will be using them. There are a number of work streams on back office function, as you might expect, including payroll, sterile services, occupational health, and legal services.
Hello, my name's Jeanette Watkins. I'm the Programme Director. Our ambition is now to take this partnership forward, building on what we've achieved to date, and we're proposing to do that by building a high-level joint clinical strategy that will require a new appropriate powered governance arrangement for delivery based on a confederated approach. The focus will be on sustainable models of acute care for both our smaller hospitals and our multi-site trusts, and it will utilise a 3-tiered approach to identify the best clinical and business models. So it will be reviewing what's to be provided at local core services at each hospital to keep the interconnected and indispensable services stable and sustainable, identification of other services that are intrinsically linked, which are not fundamental to sites, but where organisations are willing to review alternative ways of delivery, for example, lead provider or hub and spokes. And looking at also our specialist service models based on tertiary centres, which will include managed care networks, options for specialist chains, and risk tier patients to where they need to go with the most appropriate acute needs. The collaborative strategy will therefore support the development over the next 12 months by ensuring that service models are networked across the partnership where they're not sustainable on their own. Create more clinical formalised networks to oversee clinical and service standards. Reduce variations of care through standard operation policies and agreed clinical pathways. Establishing new job roles for hard-to-recruit staff. Greater standardisation of processes and use of technology for cancer referrals across the trusts. Networking radiology and pathology reporting systems and developing our overall digital strategy. New operating models will also be undertaken for back office functions with joint ventures, and we'll certainly be further developing with our commissioners and expanding our public engagement and consultation approaches.
Hi there, my name is Des Breen. I'm the Medical Director for the programme. So why us? Well, I think we've got a track record already over the last 18 months or 2 years of collaboration, both on clinical and non-clinical services, over about 25 projects. This is not just between the trusts, also but with commissioners and many other stakeholders. We've certainly developed trust within the 7-partner organisation, and we've certainly got a governance structure which is established, which we now know we need to develop further. We're working with a set of principles which we've all agreed to try and break down some of the traditional barriers of 7 independent acute trusts who traditionally were competing against other, who are now trying to collaborate. Crucially, the chairs and the chief executive officers have agreed to deliver a joint clinical strategy over 5 years, which I think is unique, and they are committed to a more federated model with a 5-year collaborative strategy. So we know that we need to actually start to develop our governance structure and change the way so that we can actually develop things further. We need to realign our decision-making process to make sure we can do things in a quicker and more productive way. We know that we need to develop our processes for the potential changes which will provide improvement in quality of care. And we're setting up joint ventures which will involve a new leadership and accountability arrangements for both clinical and non-clinical services. And we certainly are already engaged with commissioners, but we know how crucial this is because we don't want to design a product that is not fit for purpose. And also they are our crucial link to our well-established patient and stakeholder involvement.
Okay, so just to briefly summarise, we feel that we're tackling the big issues that are affecting acute care in the NHS, both as providers and as commissioners. We've got a partnership and co-creation and learning approach and track record that reflects the Vanguard approach and ethos. We're developing a clear structure and process to deliver our outcomes. We've developed standard work for application locally and replication nationally. We want the programme to help. We want advice, we want guidance, we want to help break through in key areas and accelerate our programme, our cultural change and our learning and sharing for the benefit of the NHS and its patients, both locally and nationally. Thank you.
Thank you very much. Questions? Questions for working together?
Thanks. Steve Judge from NICE. It's a question I could probably have asked of any of the applicants today, so I guess you're just the lucky ones. If there was one area of support that you were really looking for from any of the signatory organisations that are supporting this programme, what would it be?
As very early on, we took legal advice because we're quite clearly flying in the face of conflicting policy. So on the one hand, we're monitors saying compete, whereas the thrust for now is collaboration, and somehow we've got to actually get through that. And if one of the things that the 7 organisations could help us with is breaking down some of that barriers. And the second big barrier that we've come across, which we have got mechanisms in place to get round of, is the way that the funding stream is worked, because there is a perverse incentive for some of the funding mechanisms mechanisms. And also our programme is about a redistribution of clinical services, not a centralisation and local. And by the very nature of those things, we will be redistributing more profitable work into other areas, and there has to be some accountability and address for that, as some of the bigger centres tend to actually inherit the less profitable or loss-making areas. So if there's only one area I could pick, it was the help with the national barriers.
So we've got a question from the last back table in the middle. And then could somebody take a mic to Sam, please?
Hi, Manish Kishu from the Royal College of Pediatrics and Child Health. You mentioned some work regarding children's surgery. Could you elaborate in terms of your program, what you have achieved in terms of key standards of care for children in the last few years, and what your priorities going forward would be?
We've got two areas involved in paediatrics. One is the acute care, the physician element to it, which has just started, but we've actually more ahead on the surgical services. We developed a joint work stream with the commissioners. We've had several workshops involving clinicians and nurses and allied health professions across the whole region. And this has been going for about 9 months. It's also been backed up by the recent publications of the paediatric standards. So at the moment, we've identified what are the key core services for paediatric surgery that could be provided in each local trust as a minimum, and then when we've actually got things that are non-sustainable is how we are going to redevelop that. So for instance, a cut-off for a fairly fit child from an age-related point of view from anaesthesia from an age-related point of view is very different to the cut-off for what an orthopaedic professional may be able to be expected to do in a district general hospital. And very much more, the more difficult one is about paediatric general surgery, where the cut-off for age-related things for acute abdomens, for instance, is much higher, based on the changing workforce that paediatric general surgery has been stripped out of most general training. So where we are at the moment, we've got a matrix, because we've got so many principles of the programme, but we want to deliver as much close to the patient as possible, but then redistribute and sort of consolidate where necessary. And so we have a matrix building up of what core services should be for paediatric surgery in a district general hospital from a minimum bar point of view, and then how we are going to then deliver the rest. And it doesn't always mean being centralised in Sheffield Children's Hospital.
So we have a question from Sam over here.
Hi, over here. Just one of the challenges with days like today, and you'll have heard it yourself, is everybody's saying the same thing. So we're here to drive change, we want to collaborate. I'm looking forward to a time when someone says we want to work by ourselves, not work across the local population. So my question is, what's your unique selling point? Why you above all of the other 29 Vanguard applicants, and in kind of less than 3 lines?
Sure. I think there's no second chance at this point in the stage of the development of the NHS. So I think the key issues for choosing vanguards will be the potential for success and the potential for replicability, I can't say it either, across the NHS. So we haven't just thought of this for this vanguard process. We started our thinking in 2012. We established ourselves in 2013, and we have an established track record about being able to deliver in this collaborative fashion. So we think we've got a lot of things to share with the NHS, but equally to learn from the NHS about taking things forward, and that's with the best predictor for future success.
Final question, if we could just keep it very brief.
So Liam Brennan, College of Anaesthetists. Just one question that I could have asked anybody today. We've all, the approach from the stage has been that this has all been well accepted within your organisations. There must have been resistance to change, and with larger collaborations that's going to be greater. How do you manage that?
That's very interesting. Certainly, to take any of the clinical models, for instance, we certainly involve the clinicians right from day one, and that's to include both the medics and the nurses and the allied health professionals. We're not a programme about actually creating models and forcing down change. All these changes have come from bottom-up approach, and essentially it starts off with a workshop which we usually facilitate to make sure that the dialogue is dissolved. And what we're trying to do is dissolve the clinical models and rebuild them, because if you ask 2 hospitals, you're going to ship one service, which one do you want? There'll be a fight and there'll be a winner and a loser. So we're trying to actually dissolve all that, and we've got quite skilled in the facilitative mechanisms to be able to do that. Then the models are actually built up by the clinicians, and then when we've got models built up by the clinicians and allied health professions,